Thank you so much, and good morning, everybody, and thank you for having me again. Last summer, I believe I spoke to many of you about clubfoot, so I was tasked with going over congenital foot deformities, which, of course, besides clubfoot, there are abundant number of. Today, I'd like to go, let me see if I can click. I'd like to go over some of the deformities that I'm quite familiar with just because this is what I see in my practice. So we'll cover a little bit on the forefoot, cases of polydactyly and then macrodactyly, then go into work our way back toward the hindfoot, go over Calcaneovalgus treatment, congenital vertical talus, and tarsal coalitions. And I'll just kind of give you an update on what we're doing. And so I'm not going to be including metatarsus adductus, where the treatment really hasn't changed. It's basically casting. I have not seen a lot of skew foot, brachydactyly, or I don't really do a lot of amniotic constriction band cases. Those are usually in the domain of the plastic surgeons at our center. So on to polydactyly. So polydactyly is the presence of supernumerary digits. Most often it's in the postaxial location. There can be central polydactyly as well as preaxial polydactyly. It's usually, it's equal in both males and females. And oftentimes people will have polydactyly in their hands about 34% of the time. It can be sporadic or genetic. And we generally do surgery for the sake of the foot fitting into a normal shoe and for cosmesis. And generally, if I see a baby with a polydactyly, I'll advise the parents to let the baby grow a little bit more so they're safer in anesthesia, but maybe before they really start walking. So generally, the sweet spot for me is anywhere between like 10 and 11 months of age. I have a case that happens to be in a child that came at 24 months of age, and she had a duplicated syndactylized fifth and sixth toe. And you can kind of see in the picture on the left that the nail is shared. So with this, of course, we get x-rays just to see what the metatarsal is looking like, how it's shared. Is there a duplicate metatarsal? So for preoperative planning, we have the x-ray, and then our solution is to just, or at least mine at that time was to just perform a wedge resection of the accessory duplicated toe and take the nail that was just lateral to the nail of the fifth toe. So kind of approximating that and then just pinning it. I usually do that for 2 weeks, especially if they're really young. I put them in a cast with the pins, have them come back, take the cast off, remove the pins at 2 weeks. And this is how that child looked post-operatively. Okay, a little more extreme, which was a recent case that I did with one of my colleagues, is a case, definitely a case of postaxial polydactyly, but this patient had a deletion of 16q and basically had a mirror foot. I had never seen this in my practice before, but I thought I'd share it because technically it's polydactyly and I think it's pretty interesting. The x-rays show kind of a mirrored foot, but if you look carefully, even at the hindfoot, you can see that there's a duplicated calcaneus. And so that was also addressed as a stage procedure. This patient had also a tethered cord and an imperforate anus. So there were other medical issues that we had to deal with. So we didn't really get to take the ray resection until long after the other medical issues that were more important than orthopedic at the time have those taken care of. So we went on to perform a ray resection of the mirrored foot, which you can see we left the very lateral aspect, and oh dear, okay. And then pinned the toes to stabilize them. Those pins remained in for 4 weeks with the patient in the cast. And then about 7 months later, we debulked the second calcaneus. and also had performed a little bit of serial casting because the patient was inclined to dorsiflex, plantar flex quite a bit. So that we did a little bit of serial casting and prior to this reconstruction. And then one issue that we did have, you can see it in the middle at the heel. This patient had an ulcer that was a little bit vexing to deal with. However, he is now walking with without any device. He doesn't like the AFOs, but we managed to get him almost to neutral, and he's ambulating. So that was kind of a fun case, a good win. Next is a little bit about macrodactyly. We've kind of had a run of these patients with local gigantism. The macrodactyly can be congenital or acquired, but because we're talking about congenital today, I'm going to stick to that. Like polydactyly, it's equal in both sexes and can occur in isolation. The three main congenital causes are neurofibromatosis, Proteus syndrome, and Calcaneonavicular. All of these affect overgrowth and regulation of cell growth. And so oftentimes there's an asymmetric overgrowth, and they're classic kind of findings in these cases with neurofibromatosis. They have the cafe au lait spots and axillary freckling. In Proteus syndrome, which comes from the Greek sea god that could change form, you can see the patient having difficulty with the eyes as well as the hands. And then in the Calcaneonavicular, the classic Fort Weinstein, usually associated with both capillary and venous malformation, and usually it affects only one limb, and sometimes those patients can also have polydactyly. So generally, the classification can be in static, as if it's present right at birth and kind of grows proportionately with other digits, or progressive, where it's not as noticeable at birth, but then disproportionately grows over time. Can I just pause for 1 second, Vincent? Is the pace okay? Are you guys, is this helpful? Is this all right? And then you guys do questions at the end, or should I pause for any questions?
Yes, we do questions at the end.
Okay, and the pace is okay? Okay. Sometimes I talk too fast. Thank you. Okay.
Don't worry about it. Yeah.
Oh, okay. So just the operative intervention it is for cosmesis, but of course function to be able to fit into shoes. If we can, we perform the epiphysiodesis, which is very effective since we've learned how to do that so well in the knees, and we generally use the length of the digit of the same-sex parent to determine when it's time to perform this. Additionally, of course, we have to do multiple osteotomies or liposuction for severe deformity. While we're in there, we'll get sometimes, especially if the patient is younger, for just debulking, we'll get the skin biopsy to help the geneticists with confirming the diagnosis. And then, unfortunately, sometimes amputation ends up being the best in certain circumstances. Moving to the back a little bit, we're going to talk about Calcaneovalgus, which we see relatively commonly. It is something that's completely fixable with stretching. It's basically the foot has extreme dorsiflexion with the sole of the dorsum of the foot against the anterior leg. It's generally positional, occurs about 5% of the time in newborns. And it's important to look for posterior medial bowing to make sure that you're not confusing it with that, because of course, if it is posterior medial bowing, they can have limb length inequality, and you want to continue to follow them for that. Generally, the stretching, since the foot is up and out, I tell the parents stretch down and in, usually with each waking diaper change, and usually for about 10 to 15 seconds. And generally by about 3 to 4 months of age, it corrects completely. What I do in the real recalcitrant cases is I will do a long leg cast similar to how I would treat a clubfoot or a congenital vertical talus, but that's pretty exceptional. I do end up following these children into later years just to make sure that, because they will often have a flat foot, just to make sure that there's no pain. So with a follow-up maybe in a year or two when they've been ambulating for a while. I have that next to this important congenital deformity, congenital vertical talus, because sometimes it can be confused. They look similar in that the congenital vertical talus appears like the heel is in extreme dorsiflexion, but really it's in plantar flexion, and the condition involves the whole foot with the landmark features of having a rocker bottom sole that you see in the middle picture, as well as the lateral crease in the midfoot. Just this tends to be rigid, although we do stretching casts, but it's usually not fixable like the calcaneovalgus just with stretching. As mentioned before, there's hindfoot equinus and forefoot dorsiflexion, but it's a reversed arch with that lateral crease. And of course, a thorough exam to ensure that there are no other associated conditions, because there's a high rate of congenital vertical talus with other syndromes such as arthrogryposis and myelomeningocele. Generally, the diagnosis, in addition to those clinical features, is made with a lateral forced plantar flexion radiograph. So you can see all the way to the left where I've put the blue lines, because they don't have those tarsal bones ossified yet. You can see how the talus axis is quite perpendicular to the calcaneus, and relative to the first metatarsal, it's completely displaced. And then the very far right image gives you the AP view, where you can really see the lateral crease due to the dislocation between the navicular and the talus. So just on to treatment of this. Matthew Dobbs really helped us with making this, in some cases, similar, because he's a master at Ponseti technique. He did this with the congenital vertical talus, and was able to make this operation a much simpler one in many cases, where we used to take out the talus. I mean, it's crazy, or the navicular. The treatment we start with all patients, even if they seem like they're super rigid, is always initiated with serial casting and initial manipulation to stretch the dorsolateral soft tissues. You can see the thumb is applying gentle traction over the sinus tarsi, and the index finger on the other side provides a fulcrum for the plantar medial aspect of the talar head. Then you see reduction through the midfoot with an adduction plantar flexion moment. So trying to draw that navicular onto the head of the talus. So I generally cast until I can't get any more correction. Generally, the casting really stretches out the anterolateral structures. Surgery is usually done before the age of 2, and open reduction of the talonavicular joint with pinning, and of course the Achilles tenotomy, followed by cast treatment for 4 weeks when I pull the pins, and then I keep the foot in for another 2 weeks, and then into a foot abduction orthosis. But instead, like the Ponseti, foot abduction orthosis at 60 degrees external, these feet are just kept at 0 degrees straight. Just a word on the cast. We do just like the clubfoot. We kind of start with a short leg cast and work our way up to the groin with a 90-degree flex at the knee to prevent the cast from shifting off the kicking baby. And then post-casting, you can kind of see that there's been a little bit of, now they're kind of within the same zip code, the talus and the first metatarsal. It is definitely not perfect and requires surgery here. The other modality that really helps us is ultrasound to assess the talonavicular joint, since it's largely cartilaginous. So you can see at the sketches above showing how the navicular is dorsally displaced in neutral, but also in plantar flexion, and below are just how they appear on the ultrasound. Full disclosure, whenever I do this, I always do it with the radiologist because I don't always know what I'm looking at. It's not as easy to me as it is for hip dysplasia. And then the minimally invasive procedure just is often sufficient unless the feet are super stiff, in which case we do kind of an a la carte and sometimes with a naviculectomy. I have never had to do that, but one of my colleagues who does largely foot surgery has to do that on occasion. And then this guy had a pretty nice outcome. So you can see on the right side how the talus is converging nicely with the calcaneus and in line with the first metatarsal. And then lastly is one of my favorite topics, which is tarsal coalition. We see quite a few of these, and I might have a little bit of a biased opinion regarding being a little more aggressive with taking them out. It is an ancient condition, as you can see from the picture on the right. There is a genetic influence. The FGFR3 has a mutation and sometimes can be associated with craniosynostosis and brachydactyly. Most of the time, these patients with tarsal coalitions present to us when they're older, so we don't generally have to look for the other conditions because they're mostly just normal children without any other diagnoses. But the incidence is anywhere from 0.4 to 13%. But that's probably an underestimation because there are people that probably have tarsal coalitions and don't even realize it. And some can be asymptomatic. So 3 primary pain generators in a tarsal coalition is that there can be motion through the synchondrosis. It can be due to malalignment caused by the stiffness of the coalition. And it's also largely due, and this is why I'm more aggressive with surgical intervention, is it can disturb the kinematics because the adjacent joints are being asked to do supraphysiologic motion beyond what those joints are normally accustomed to. And I just put this picture on the right just as an analogy. Our fingers aren't meant to hyperextend, and that's what we're asking the adjacent tarsal joints to do when we leave a symptomatic coalition. So we'll start just with the calcaneonavicular, generally seen in slightly younger children. Here you can see that there's a connection between the anterior process of the calcaneus and the navicular bone. This we best see radiographically on the internal oblique X-ray. This just shows that it can be variable morphology. You see that the foot on the left has almost a bony connection, and the middle has a synchondrosis with the, and then the last one's sort of variable. So they come in a little bit of different shapes, if you will. I generally do get 3D imaging prior to surgery, 1 to confirm that there's edema at the coalition, and 2 just to look for other coalitions so that we can address everything in one surgery. Here you can see in the MRI confirms kind of a coalition both at the calcaneonavicular location, but also on that axial view you see the Talocalcaneal coalition. Generally, I perform surgical incision just through a small Ollier incision. We have to watch out for the superficial pharyngeal nerve. It's almost there every time we incise. I generally lift the extensor digitorum brevis to get to the coalition and use fat graft. Pretty particular about making sure that there's no bleeding after we resect the coalition, just to ensure with bone wax, just to prevent recurrence if that's a possibility. But I really think if there's recurrence, it's probably because I didn't resect enough of the bone. We have the Zeem spin, which allows us to do the 3D kind of a CAT scan in the OR, which is really helpful. That's been a nice utility of it for checking that the coalition is completely resected. And then just onto the talocalcaneal, happens in a little bit of older children, pre-adolescents to adolescents. And you can see the image on the right shows the classic C sign, indicating that there might be some connection of the talocalcaneal region. And again, 3D imaging, I use this, but also what's also associated with talocalcaneal coalitions is you can get beaking either on the dorsal edge of the talar head or the proximal aspect of the dorsal navicular, or both. I'd be interested to hear any foot mavens' thoughts about if they ever do anything with that bump when they do take out coalitions, especially if there is discomfort in the patient. We're kind of divided. Some of us take that out and some of us leave it, feeling that once you alleviate the stiffness from the coalition, those symptoms go away. The Saltzman view is a nice way to confirm the coalition. We generally do this weight bearing at about a 20-degree angle. That's a nice, helpful way to really illustrate the coalition without 3D imaging. But of course, I do use 3D imaging to confirm and co-localize the coalition, just to know the extent of it, just for preoperative planning, because you can see on the right side how this coalition really incorporates the entire middle facet. But sometimes we get the posterior facet as well. So this is helpful just to plan preoperatively. And here just shows the variable morphology of the talocalcaneal coalitions. I use the MRI again to look for the edema, just to kind of confirm along with the clinical picture. Generally, if they have the stiffness, the rigid flat foot, and pain on palpation of the region, it's generally enough indication for me to proceed with resection. That this incision is a medial one centered over the flexor digitorum longus. I open the sheath and retract the tendons, which help find the flexor hallucis longus, and by reflecting that, it protects the posterior tibial and medial plantar nerves. You don't always find that nice stripe of cartilage, so I like to use the Zeem spin to kind of help orient, but also the 3D imaging prior to surgery helps prepare for that. And just like the talocalcaneal coalition, the Calcaneonavicular coalition, once the resection is performed, I place fat graft in from the gluteal region. And I think that's all I have.